that we will have a question, sort of a practice series of practice questions. And also I will show you some slides which are sort of commonly given at the exam also, or tell you some things which are commonly given at the exam so you can study around them. Right? So this is not purely any class we will do a sort of a few mock questions and also do a few sort of related stuff and commonly asked stuff at the exam. Okay. Right. ප්‍රශ්න කියද්ද කියලා කිව්වද මේ පොඩි? විසද්ද?
නෑ සර්.
ගියාම තමයි දැනගන්නේ. හරි හරි ගියාම තමයි දැනගන්නේ. කවන්නේ කීය තිබ්බත් උරු ප්‍රශ්නේනේ. I think you will have paper-based ones. It's very unlikely that you will get a patient or clinical stations. Very, very unlikely. Apart from the sort of history taking communication skills, ethics in a station, the other ones will all be paper-based, most likely, right, given the current situation. Right. So read this and try to answer. Don't know, but I just think of the answer that you will write if you got this for the exam. Okay, just glance through that. I'll show you the pictures also, right? So basically, there is a patient who's developed fever and mucosal ulcers, and he has been recently started on some medication for joint pain, right? And this is the clinical picture of the patient for you to make a diagnosis. Right. Okay. So it's quite clear from the pictures that the patient has plaque psoriasis. Plaque psoriasis. On the picture, the forehead picture, you can see very clearly this pinkish scaly plaques, which is by definition the psoriatic plaque. It's a pinkish scaly plaque. And of course, if you try to sort of scratch it, it starts bleeding, right? And also this pinkish scaly mark. The fact that the plaque is crossing the hairline here is also quite significant because that is another feature of psoriasis. Samhara velavati, you can, when it occurs on the scalp, you can mix this up with seborrheic dermatitis. And this is important as a point to remember that seborrheic dermatitis does not cross the hairline. The lesions in psoriasis, however, do cross the hairline. So pinkish plaques, a bit of bleeding there, crossing the hairline are suggestive of psoriasis. And in the hands, you can see the nail changes, nail pitting, onycholysis. Mouse point, laser point. So this area is onycholysis, as you can see. So pitting and onycholysis are two important features, psoriasis-related nail changes. Right. Now, what has happened is, if you look at the blood report, the patient has developed pancytopenia, right? Pancytopenia, and even more importantly, neutropenia, significant neutropenia, pancytopenia, neutropenia. And we know that this is a famous side effect of methotrexate, right? Methotrexate. And psoriasis in a patient, psoriatic arthritis, methotrexate is one of the first line drugs that we use. So this is methotrexate-induced pancytopenia with neutropenic sepsis. Where the neutropenia, where the neutrophil count is less than 500, fever indicate neutropenic sepsis. Hari. So management steps can have management steps can have obviously all the points in sepsis management you can write, but remember in neutropenic sepsis specifically, we use piperacillin tazobactam as the first line antibiotic. Right? Piperacillin tazobactam as the first line antibiotic. The reason for that is, in neutropenic sepsis, you need to cover for pseudomonas. And piperacillin tazobactam is an important, good anti-pseudomonal antibiotic. So that is the reason why I use piperacillin tazobactam. Right. Okay. So when it comes to dermatology, you can get other pictures, and these are some of the common things that we see in exams, right? This is what is this? So you can see the typical target lesions, mere target lesions of erythema multiforme, and you need to know a few causes of erythema multiforme, right? So this is erythema multiforme. The target lesions you can see there, quite common pictures at OSCEs. Right? This you can see, these are painful lesions in the shins, right? This is erythema nodosum. Okay, we quite commonly see this. Examples for causes would be sarcoidosis, inflammatory bowel disease, right? Tuberculosis. These are all causes of erythema nodosum. They are painful, tender nodules usually. Right? So here you can see another very common OSCE that you see in exams, the typical sort of mela butterfly rash distribution of SLE, right? SLE. හරි ඕක ටිකක් බලා ගන්න. මේ දෙන නිතර දිනේ මම මේ උදාහරණ වලට දීලා තියෙනවා. Right, this again is a very common picture that you get at OSCEs, and the diagnosis here is systemic sclerosis. The typical features you can see are in the face. You can see the very tight skin. So it's a tight, shiny skin, beak-shaped nose. You can see that the skin on top of the nose is very tense, right? Causes a beak-shaped nose, right? The patient cannot open the mouth because the skin is so very tight. The patient can't open the mouth, and that is called microstomia. So microstomia, thin, shiny skin, thick, shiny skin, beak-shaped nose are all features of systemic sclerosis. And also you see this whitish sort of patchy rash in the trunk and the neck. That's called speckled leukoderma. Speckled leukoderma. It's called speckled leukoderma, and that is in the sort of neck and chest regions that you see. In the hands also, you will see the similar changes, the very tight skin, and sometimes you see, like in this patient, tissue loss, right? Tissue loss because of vascular constriction, right? Sometimes these people get very serious vascular constriction and gangrene and tissue loss as well. So that is a serious problem that we sometimes see with systemic sclerosis, right? Severe Raynaud's phenomenon, vasoconstriction leading to tissue loss. Right? So this again is a very common thing you see in OSCEs. The case scenario will go something like: patient was recently treated for epilepsy with some anti-epileptic drug, comes out with this rash. So all of you know that this is Stevens-Johnson syndrome, maybe a bit of toxic epidermal necrolysis overlap. So you can see some peeling of the skin. The mucosal ulcers, the mucosal lesions are suggestive of Stevens-Johnson syndrome. And this skin peeling also, you can see in places the skin has peeled off, and that is when it's overlapping with toxic epidermal necrolysis. Anti-epileptic drugs are very famous to cause this syndrome. Carbamazepine is one famous culprit. Lamotrigine is the other one. Okay, lamotrigine and carbamazepine, right? Famous to cause Stevens-Johnson syndrome and toxic epidermal necrolysis. Right? This again is quite common. You see these hypopigmented patches in the face, can occur anywhere, hypopigmented patches. And also in this patient, you can see this greater auricular nerve thickening. I mean, laser point taking that around that. So greater auricular nerve thickening, hypopigmented patches, commonly in the face, trunk, leprosy, usually tuberculoid or borderline leprosy, right? And then the more extreme spectrum would be this. You can see the eyebrow and forehead infiltration, right? Then this is earlobe infiltration is mostly seen in lepromatous leprosy. This is called leonine phase. Lepromatous leprosy. leprosy is quite common again in your OSCE's pictures. Right? Dermatology වලට දාලව. So that's essentially what you might get. So psoriasis is a very common thing. Systemic sclerosis is a very common thing that you will get. අනිත් ඒවත් leprosy වගේ දේවලුත් දෙන්න පුළුවන්. Right. So the second station now we are focusing on ECGs. Right. Now I've done a detailed class on ECGs, so we can just discuss these quite quickly. Right. If you have any questions, please put them on the group chat. Okay, or just ask them. Right. So 35-year-old relatively young person with palpitations, right? And analyze the ECG like I have taught you here. When you know palpitations, you know it is a rhythm analysis that you're supposed to do, right? And if you look at lead 2, again, I emphasize that lead 2 is the most important lead to look for rhythm changes. And you can see P waves and, sorry, you can see QRS complexes, which are narrow and normal looking, but no P waves. This is a T wave that you see here. Right, so these are all, this is a T wave that you see there, right? No P waves are seen. So now you know that this is a patient with nodal tachycardia. I also told you that nodal tachycardia is called AVNRT or SVT, right? That is a, you might get retrograde P waves in this condition, and here you can see a small retrograde P wave here, right? Just after the R wave, you see a very small notch-like thing. That's the retrograde P wave. But in lead 2, you cannot see any obvious P waves. So you can see this is a regular rhythm. Arrhythmia කනකොට මේ ගැන කතා කරා regular, tachycardia, there is normal QRS, narrow QRS without any P wave. Retrograde P waves are seen in some leads. So this is SVT කිව්වත් හරි, nodal tachycardia කිව්වත් හරි, AVNR කිව්වත් හරි. Right? All are acceptable answers. So management we talked about. Stable or unstable is quite important. If the patient is unstable, then you need to shock the patient. If the patient is stable, you can try vagal maneuvers or adenosine, right? If you do not have adenosine, then you can use IV calcium channel blockers, right? So arrhythmias, definitely we get one ECG on arrhythmias, right? Some tachycardia, something you will get. Right. Now, other ECGs, of course, I'm not included in this presentation, but complete heart block, right, is a very, very common ECG that you will get. So please look at, we did this when we talk about ECG. Complete heart block is a very common ECG that you will get. These are some other ECGs. So what do you think in this? So again, most of these rhythm abnormalities, you will have the answer in lead 2. So have a look at that. I'll give you a few seconds to work this out. So QR is looking okay, but you can see that this the P wave is reduced to an irregular baseline, right? You don't see a well-formed P wave. What you see is an irregular baseline in between the QRS complexes, irregular baseline. And you can see that the QRS complexes come in at irregular intervals. They don't come in at the same times. They come in at irregular intervals. You can see this very nicely here. Irregular intervals there, and there. So completely irregular intervals they are coming in at. Right? So completely irregular intervals. So this is atrial fibrillation. Atrial fibrillation. Now, two important things about this ECG. If you look at lead V1, you might be tricked into thinking a flutter wage. You can see it's a flutter sort of thing, sort of flutter wave like thing. But remember, in atrial fibrillation, you can get this appearance in V1. It is not flutter, it is atrial fibrillation. You can get that appearance in V1 like a flutter wave sort of appearance. Right. The other thing that I want to point out, and this is not essential for you to write at the exam, is that if you look at the ST segment, ST segment is shaped like this, right? It goes like this. This is called reverse tick, reverse tick, T-I-C-K, tick, reverse tick, right? Reverse tick pattern of the QRS complex. So reverse tick pattern of the QRS complex, right? Reverse tick pattern of the QRS complex. This occurs when the patient is on digoxin, right? This pattern occurs when the patient is on digoxin. Those are two additional things that you need to notice in this. So the flutter-like thing is not really flutter, it is fibrillation. You can see flutter-like waves in V1 in atrial fibrillation. That is a usual phenomenon. And you can see the sort of down sloping, or sort of we call it a reverse tick ST segment when you know the patient is on digoxin. I taught you last week that when you have atrial fibrillation, one of the rate controlling drugs are digoxin, right? Digoxin. Okay, have a look at this one also. And remember, right, so this, you can see the flutter waves. Right, so these are flutter waves. Remember, flutter is best seen in the inferior leads. Remember that. Okay, flutter is best seen in the inferior leads. So 2, 3. But you can very clearly see the flutter waves in 2, 3 and A wave. Sawtooth sawtooth P waves in flutter. So that's flutter, just as a revision. මේකත් ඔයගොල්ලන්ට මතක ඇති අපි ඉගෙන ගත්තා මේක. So broad complexes, tachycardia, ventricular tachycardia. This is monomorphic ventricular tachycardia. Right? And you can see this ECG very nicely shows Torsades Dupont, right? So you can see this twisting ribbon-like pattern of the QRS complexes. මෙහෙම රවුමට ගිහිලා තියෙනවා. Torsades Dupont මම ඔයගොල්ලන්ට කියලා දුන්නා. Remember, commonly seen in hypokalemia, hypomagnesemia. And the first line drug for treatment of Torsades Dupont is magnesium sulfate 2 grams intravenously. So one iterama dena deval. So complete heart block ECG mama metana dala naha, but that is something that we give you. Atrial fibrillation, atrial flutter, supraventricular nodal tachycardia, ventricular tachycardia, Torsades Dupont are very common ECGs to get. Right. Okay, so another ECG. So usually in your 20. Oh, can. Yes, Pratibha. Yes.
So when the question is what's the abnormality you see, is it ventricular tachycardia we say, or is it broad complex?
It's better to write that it's a broad complex, broad QRS complex tachycardia with multiple sort of morphologies. Polymorphic. And then after that you say it's polymorphic VT. So write the diagnosis and the description of the abnormality. So here you write, right, tachycardia, flutter waves in V2 in the inferior leads, atrial flutter. Right.
Thank you, sir.
Right. Okay. So let's go to station 3 now. Read this and see if you can come up with the answer. So patient on chemotherapy for carcinoma of the breast, recurrent episode pre-syncope. What is the most likely diagnosis? And remember, this mock task is slightly difficult, more difficult than you would get at the exam. So don't get depressed if you can't answer any of these questions. Right. Okay. So this is a slightly tricky one. If you follow the history, you might get a bit of a clue. But what this shows is, right, you can see these sort of ST elevations. ST elevation. So ST elevations in V1, V2, V3. Right. Inferior. So you can see that there are ST elevations in the V1, V2, V3 sort of territory. Now, you have to be careful. Make a STEMI කියලා ලියයි. Namuth that is not the absolutely correct answer here. when you have something going on in the right ventricular leads, right, especially ischemic changes, ST elevation, ST depression, it is very, very important to think of pulmonary embolism. Right? Pulmonary embolism. So this is called right ventricular strain. These are actually ischemia, but ischemia due to strain on the right ventricle. And also, if you look carefully, you can see this classical S1, a deep S wave in lead 1, okay, Q wave in lead 3, and T inversion in lead 3. So this is classical S1, Q3, T3 pattern. So right ventricular strain with S1, Q3, T3, this is more suggestive of a pulmonary embolism. So right ventricular strain, what I mean by that is there are ischemic looking changes in V1, V2, V3. That can be ST elevation, it can be ST depression, whatever it is. And in addition, you might see these sort of classically described ECG abnormalities like S1Q3, T3 in the sort of ECG as well, right? With tachycardia, that's other common abnormality you will notice in patients with pulmonary embolism. And remember, pre-syncope, syncope are very common presentations of pulmonary emboli because it's sort of strain on the right ventricle, the cardiac filling is compromised, output is compromised. So that is a reason. Okay. All right. Fine. So this again, and how you confirm the diagnosis of pulmonary embolism is through a CT pulmonary angiogram. Hari, station 4 මම ඇත්තටම මේ repetition එකක් අර ECG එකම තමයි මේ කරේ. So tossard stipons, and you can see this part in මේ කැල්ල is ventricular fibrillation probably. හරි, මේක පොඩ්ඩක් VF වගේ ගතියක් තියෙනවා. This is more tossard stipons. So, හරි. And I told you the main reason for tossard stipons is hypokalemia, and in this ECG you can see this is a, right, so this is the T wave, right, URST, and this is the U wave. Make a very common ECG එකක් exam එකේ දෙනවා නිතරම. හරි. So U wave. ඒක අමුතුයි වගේ පේ T එක ඇත්තටම පල්ලෙහාට තියෙනවා. T inversion, and then you have this tall thing that is the U wave. So this is hypokalemia, and if you connect the two ECGs, you can see that this tossard stipons was triggered by hypokalemia. Right. Okay, so be careful. The other ECG that you can get is hyperkalemia, and I showed you some examples of hyperkalemia when we were doing the ECG class. So please have a look at those also. Right. Then another set of ECGs you can get with chest pain scenarios, and we did these ECGs when we were talking about when we were doing the ECGs, and I showed you this very, very same ECG. So remember I talked to you about lead orientation when we were talking about the ECG. So remember V1 to V6 is anterior, 2-3 AVF is inferior, 1 AVL is left, right? So that's quite important to remember. Otherwise you cannot work out. Make a STEMI, you can't just write STEMI and come off. You won't get any marks. You have to write STEMI and say where the STEMI exactly is. So in this patient, it is in the anterior part of the heart, anterior. And then most importantly, you can see inferior. I showed you this very same ECG, 2-3 AVF. Right. Now, another ECG that can appear in the exam is this, and this is a left bundle branch block. Right. Then make a William Marrow is how you remember bundle branch blocks. And remember, in a left bundle branch block, this is a key feature to look out for, a very deep S wave in V1 and V2. Because you might not clearly see this William, but you can see this very deep, sort of broad looking S wave in V1 and V2, which is again a feature of left bundle branch block. Right. So ECG ECG is STEMI ECG are very commonly given. Arrhythmia ECGs we have gone through. Hypokalemia, hyperkalemia important. bradycardia, complete heart block would be another very, very important ECG. So, ඒක බලා ගන්න අනිවාර්යයෙන්. හරි. Any questions up to now before we move on to the chest X-rays?
The patient දෙන immediate drugs මොනවද කියලා ඇහුවාම අපිට මේ දැන් STEMI එකක් නම් අපිට එතකොට tenecteplase එකමත් ලියත හැකිද?
So when they say immediate drugs, you can write anything. ඒක ඕන දෙයකට ලකුණු දෙන්න ඕනේ නේද? Even specifically ඇහුවේ නැත්නම් aspirin, clopidogrel, statin, even the morphine might be an immediate drug. So ඒකට ඉතින් ගොඩක් ඊට වැඩි specifically අහනවා ඉතින්. නේ? tenecteplase ඕන එකක් හරි. Yeah. Okay. Right, so let's move on to the next few things. Station 5 is chest X-ray. So 55-year-old male with weight loss, low grade fever, 3 months may X-ray ko gulta pennuwa kalin, right? Remember when we were doing X-rays, I told you this is a sort of, you can see very fine nodules all over the lung fields, fine, very fine nodules, and this is called miliary shadowing. Neda api me wachane පාවිච්චි කරා miliary shadowing. And miliary TB is the top differential for this, right? And then also you need to consider very small metastatic deposits, which are called miliary carcinomatosis, right? So that is what you see in this X-ray, miliary tuberculosis, miliary carcinomatosis. These are a few other X-rays that frequently appear in exams. So you can see this multiple large nodules in the lung fields, which are also called cannonball deposits. We frequently see this in things like renal cell cancer, right? Cannonball deposits. Can occur in things like thyroid cancer. Renal cell cancer is a bit more common to cause this appearance, right? Right, cannonball metastasis. Right. Another chest X-ray, right? So station 6, a 23-year-old IV drug user, chest pain, fever, shortness of breath. Chest X-ray is given below. And let's have a look. Right, so what do you see in this one? So remember, intravenous drug user, and you can see I showed you this, I didn't show you this particular X-ray, but I showed you a very similar X-ray. And then what we saw was a cavity with a fluid level, which I told you that radiological description of a cavity and a fluid level is a lung abscess. And these are multiple, you can see this, multiple lung abscesses. Now, whenever you see this picture, you need to always consider specifically the fact that the patient is an IV drug user, right-sided infective endocarditis. So that is an important diagnosis to consider. And remember, when there is right-sided endocarditis, septic emboli will go through the pulmonary artery and reach the lungs. So you get multiple lung abscesses in endocarditis, infective endocarditis, and IV drug users commonly get this right-sided infective endocarditis. Right. Another cause of multiple lung abscesses are melioidosis. Right. Melioidosis is another cause of multiple lung abscesses. Right. Okay. A few more chest X-rays that you will get at OSCEs. Right. So this one. Remember, I told you airway, airway, lung fields, heart, diaphragm, ribs. I told you when it comes to the heart, right? So you can see the abnormalities in the heart in this patient. You can see that the left heart border is straight. It's slightly difficult, but you can catch that if you know what you're looking for. Left heart border is quite straight. Another thing that I want to show you, which might be very difficult to spot, is this. So this is the outline of the two bronchi, right? The two bronchi are usually like this. But here you can see the angle has increased now, right? The angle between the two bronchi has increased. That is called splaying of the bronchi, splaying, splaying, splaying of the bronchi. You can see these sort of bronchi moving apart or splaying, and that is due to, so the left heart border and the splaying of the bronchi are due to enlargement of the left atrium. So they are due to enlargement of the left atrium, right? Left atrium, enlargement of the left atrium. Okay, so this is left atrial enlargement. Why this is relevant to us is mitral stenosis is the common cause of this appearance. If you look carefully in this X-ray, you can also see some upper lobe venous diversion. Misudu පාට පොඩ්ඩක් වැඩි වගේ නේද upper lobe එකට යන, right? And that occurs because you remember in pulmonary edema, sorry, in mitral stenosis, the left atrial pressure is high. Obviously, the valve is small, the left atrial pressure is high, and this transmits back pressure onto the pulmonary venous system, causing pulmonary edema. So that is why you see this appearance, right? So pulmonary edema, mitral stenosis due to that. So left atrial enlargement you see in this X-ray. Okay, this is not a very clear X-ray, but you can see again a cardiac abnormality, cardiomegaly. You can actually see a calcified aneurysm, but essentially you see that calcified aneurysm and cardiomegaly. And remember the X-ray changes of heart failure, pulmonary edema, upper lobe diversion, right? You can see. And also you see pulmonary hilar congestion there, hilar congestion there. And the other changes are things like curly B lines, which are difficult to spot. Right? This again looks like cardiomegaly, but don't be fooled by it. The only thing you see is a very large heart. You don't see the upper lobe diversion or anything. No upper lobe diversion, nothing. So this, and also the other important feature here, and write this down. I might not have shown this X-ray to you before, but the hila are obscured. You don't see the hila. Hila is a pain neck. Compare this with this one. You don't see the heart looks massively enlarged, but you don't see any features of heart failure on this X-ray. And the hila are obscured. You don't see the hila very clearly. So what this is a pericardial effusion. So when you have a large heart, always think of a pericardial effusion. The differences between heart failure, large heart, and a pericardial effusion are, in pericardial effusion, the hila are obscured. You don't see the hila clearly, and you don't see any of the features of pulmonary edema, none of the features, right, of pulmonary edema. Okay. Now these are also, for interest, I showed you this X-ray before. So hilar lymphadenopathy, you can get this in lymphoma, you can get this in sarcoidosis, right? And certain other fungal infections, which you don't need to worry about, right? Okay. This is very easy, pleural effusion, remember write the site, and we have talked about pleural effusions before, about likes, criteria and things like that. They might ask a few questions related to that. So description is important, all of that. Right, then consolidations we have seen before when we're doing the X-ray class. You can see this heterogeneous opacity, air bronchograms, where you can see the sort of air passages highlighted against the white, right? Air bronchograms, heterogeneous opacity, so upper lobe consolidation, right? And this is probably a more middle lobe consolidation. Again, I think I showed this very X-ray to you, right? I told you that whiteout of a side, there are several differential diagnoses. Could be a massive pleural effusion. It could be a collapse of the lung. It could be a pneumonectomy. So massive pleural effusion, pneumonectomy, collapse. And I told you that how would you recognize a pneumonectomy? When a patient, if you look very carefully at this X-ray, you will see this suit ribs couple. You can see resection of the ribs here. So rib home tibila, suddenly there is no rib there. And then you see, so it's again a pneumonectomy. X-ray. So pneumonectomy, collapse, pleural effusion are important differentials when you have complete whiteness of one side. Right? Right. Okay, these are a few more X-rays that you might get. Right. So you see this very nice reticulonodular. So what the word reticulonodular means is you have small dots and lines. You can see the lines also very nice. So reticulonodular occurs in interstitial lung disease patients, right? And mostly you can see is concentrated towards the lower lobes of the lungs, right? So reticulonodularity. Make a mukadde. Again, very common X-ray. So very common X-ray. You can see this trachea significantly deviated to this side. Right? Volume loss. That means that there's volume loss. Whatever that's going on here is causing a lot of volume loss. Right? And so we think there's fibrosis, there upper lobe fibrosis, and you can see me sudupata, so fibrous again, reticulonodular or more whitish sort of shadowing there. And you can see these cavities, cavities, so there's probably active disease also. You can see these cavities there, right? These are all cavities. Right? So upper lobe, you can see the fibrosis, which is pulling the trachea to that side. The volume loss is quite clear on this X-ray, and you see this sort of cavitating lesions all over the place. Right, so this is pulmonary TB. Right. This we have seen before, pneumothorax. Right, so X-ray ටික පොඩ්ඩක් බලා ගන්න එහෙනම් these are common exam ones, biliary TB, cannonballs, lung abscesses, cardiac abnormalities, heart failure X-rays are very easy to find. Mitral stenosis X-rays are very easy to find, so you can get that. Pericardial effusion, then pleural effusions, consolidations, things like this, for example, interstitial lung disease, apical fibrosis and active tuberculosis, pneumothorax. These are very common X-rays, right, at OSCEs. Right, okay. Fine. So let's move on to the next part, CT scans. Right? So let's focus on this question first. So from the history, you know the answer here, right? Very clear, hopefully. Right, so here you see the typical appearance of subarachnoid hemorrhage on the CT scan. So what you see is, if you look at the figure on the right side, you see this, all this white is blood in the basal cistern. Basal cistern is the base of the skull. In between the brain matter, you have the CSF running there, and you see all this is blood, and this is blood in the basal cisterns, blood in the ventricular system. You can see that there. And also you can see blood all over there, right? So this is subarachnoid hemorrhage. In addition to this showing a very typical subarachnoid hemorrhage, you also see ventricular enlargement. Ventricular enlargement peno apitame. So you see that ventricular enlargement there and there. So ventricular enlargement, because you know that when there is subarachnoid hemorrhage, you get hydrocephalus due to obstruction of the ventricular pathway or the ventricular flow of CSF. Right? When there's blood, it blocks it, and this can cause hydrocephalus. Right? So this is actually a subarachnoid hemorrhage with obstructive hydrocephalus, and it's a neurosurgical emergency. Right. So what are the other common CT scans? Very easy one. You can see this. Remember, in a CT scan, white is blood and black is infarction or water or edema, right? And you can see this very clear infarction, very demarcated, beautiful infarction in two planes. Mekama CT cuts dekak, right? You can see this very nicely, the infarction, and you can see that the infarction corresponds to the middle cerebral artery vascular territory. So it's always important when you see an infarction on a CT scan to mention in what vascular territory this infarction is in. So in this patient, it is in the middle cerebral artery territory. MCA infarct එකක් මේක. හරි. Right. So it is the commonly CT scans infarction subarachnoid hemorrhage. So it is the නිතරම දෙන්නේ intracerebral ලේවත් කලාතුරකින් දෙනවා. හරි. Right. So let's move on to number 8.
Excuse me, sir.
Oh, sorry.
Can we consider tumor in that?
This one,
Yes, sir.
yeah, there are several reasons why this is not a tumor. If it's a tumor, you will see a lot of cerebral edema and midline shift. A tumor of this size, you will see cerebral edema and midline shift. That's a good question, actually. Teaching point. So cerebral edema, midline shift. Also, another thing you would see is the tumor will not stick to the vascular territory. Now here it's very clearly demarcated to a nice vascular territory. In a tumor, it crosses vascular boundaries. So it does not restrict itself to a vascular territory. So that is a difference. Okay. So this is not a tumor. There is no edema, there is no midline shift, and it sticks very nicely to the MCA territory, all of which are features of infarction. Right. Okay, right. Station 8, the moment they say backache, headache, and visual blurring and give you a skull x-ray, there is no bloody thing that it could be, but multiple myeloma. Right? So you can see this skull x-ray with multiple lytic lesions. In order to confirm the diagnosis of multiple myeloma, you need a serum plus or minus urine protein electrophoresis, right? You need that. Or what you do is something called a free light chain assay, free light chain, serum, free light chain assay, whatever. Taking your current plan, bone marrow biopsy. Right, so skull x-ray with lytic lesions, myeloma, nothing else this could be, and very common at exams also. Right. Okay. Now I think this is 9, number 9. 9. So, okay, so we're talking about anemia and we are going on to blood films now. Right. Now, when you look at a blood film, first focus on the red cells, right? Red cell morphology. So that is the first thing to focus on, is the red cell morphology. So have a look at the red cell morphology here and you will be able to see quite big looking red cells. Almost the size of a neutrophil. Red cells are usually very small. They are size of a lymphocyte, which is actually quite small. So these are large red cells, right? So the red cell morphology seems abnormal, right? So these are large red cells. And so these are macrocytes. In other words, these are macrocytes. And they are also, if you look at the shape of the macrocyte, they are oval in shape. You can see that. More oval in shape. So oval macrocytes. Oval macrocytes are a feature of B12 or folate deficiency. The other important clue to say this is B12 or folate deficiency is this hypersegmented neutrophil. Multiple segments, usually more than 5, 3, 4, 5, 6, 7 theonometer. So usually if the neutrophil is segmented to more than 5, then it's called a hypersegmented neutrophil. Again, B12 folate deficiency, they came make a theorem. Right? So B12 or folate deficiency, oval macrocytes and hypersegmented. So remember the red cell morphology is what you glance at first. Before we have a look at that. All right. Now these are these are also some other pictures of red cell morphology, common examples that you can get at the exam. Here you can see this is a lymphocyte. You can see the red cells, some are smaller than this lymphocyte. The red cell should be the size of a lymphocyte. So these are smaller, so these are microcytic. That's one thing that you see. The second thing that you see here is that the central area of pallor, the central area of pallor is big, right? It's large. There is a large central area of pallor. And that means that the red cell is hypochromic. So these are microcytic, hypochromic red cells. And we talked about causes of this when we were talking about anemia a long time ago, but please revise these. So iron deficiency anemia, thalassemia, um, uh, anemia of chronic disease are three important causes of microcytic hypochromic anemia. Right. Right. So red cell morphologies we are talking about. So macrocytes, oval macrocytes, B12 folate deficiency, microcytic hypochromic cells we see in iron deficiency, thalassemia, anemia of chronic disease, and some other rare things like sideroblastic anemia. These red cells again are different. They are compact. You do not see any central pallor in these red cells. There is no central pallor. You don't see any central pallor here. So these are spherocytes. So you've seen macrocytes, microcytic hypochromic cells. These are spherocytes. The feature of a spherocyte is that they are small and they do not have a central area of pallor. And these spherocytes occur in hereditary spherocytosis and also in warm autoimmune hemolytic anemia. So hereditary spherocytosis and warm autoimmune hemolytic anemia. Okay, fine. Now these are also abnormal red cells, and these you can see are called acanthocytes. Right, okay. Now going on to white cells, right? So white cells are not very old, but this is something that you might get, right? Now here you can see the white cells are definitely abnormal. These large looking things with a full nucleus thing are called blast cells, these large things. But also you can see normal looking neutrophils as well. So there's a range of cell differentiation you see in peripheral blood, ranging from these blast, sort of abnormally large nucleated cells, to more mature looking white cells, which are called more mature cells. So this is a spectrum of cells you see. So these are myeloid cells, right? And these are called, or granulocytes. So this is a patient with chronic myeloid leukemia, CML. The feature of CML is you see a range of cells, various types of differentiated cells from the immature blast cell to the mature cell. So this is a range of degrees of differentiation that you see, CML. And similarly, this is CLL. This is a particular type of cell. It's called a smudge cell or a smear cell, right? Smudge color again. Smudge or smear cell, which you see in CLL. So if you are getting white cell abnormalities, you will most likely get a CML. Rarely you might get a CLL, but CML and then a purua, right? This is a sort of a nice picture that you can get. Okay, so these are the important things. So blood films, red cell morphology, macrocytosis, microcytosis, and spherocytosis are three things. Acanthocytes you might get. Then white cells, CML and CLL are the two important things that you need to know. Hari. Make a meter calling kara. I've sort of repeated that, so you don't have to worry about that. So systemic sclerosis. Hari, any questions up to now? Okay, right? Either you're sleeping or following very intently. I don't know what the hell is going on, but fine, good. Now, next we go to fungi. So the little bit of a history is given in this station. A headache for 3 months. And what do you see here? So when you're looking at a fundus lamai, right, focus on the optic disc first. So write that down. So make sure that you focus on the optic disc. Okay. And here you cannot make out the border of the optic. It's not clear. It's blurred. The word is blurred. You see a blurred optic disc. And also a lot of hemorrhages and congestion around the disc. Right? Blood hemorrhages, there's congestion around this disc. The blurred disc you can make out, and you can see this hemorrhage. So this is papilledema, right? Papilledema. Right. And obviously you need to do a scan of the head, right? There's nothing else that you need to do. Scan of the head, MRI preferably, if you find this sort of fundus. Right. You can get other fundal photographs. This is something that you can get. Here again, ignore what's going on in the blood vessel. You can see that the optic disc is very white, right? It is sort of, it's called a full moon appearance, very white or yellowish sort of thing there. And that is optic atrophy, Optic atrophy when you see a very white looking optic disc. Optic atrophy. Very white or yellowish, called a full moon appearance, right? Now here is again a very famous thing. So the optic disc is okay, but you see in the background retina around the blood vessels, these are called dot and blot hemorrhages. Right? Dot and blot hemorrhages. Small hemorrhages everywhere, dot and blot, and all these exudates as well. Body exudates, whitish yellowish thing. So this is non-proliferative diabetic retinopathy. Right? The dot and blot hemorrhages are characteristic of non-proliferative diabetic retinopathy. Very common fundus photograph. And here you see a completely different picture, again diabetes, but you can see all this. I hope you see this clearly. A neovascularization or proliferation of vessels everywhere like that, right? And this is proliferative diabetic retinopathy, right? And these things are, what do you think these things are? These are laser photocoagulation marks or laser burns in the retina. The treatment, as you know, for proliferative retinopathy is just laser therapy, and sometimes you can see these changes on the retina due to the burns, right? So this is proliferative diabetic retinopathy with laser photocoagulation marks. Very common slide. Right, okay. Right, let me show you something else before that. Yeah, so ignore that slide for the moment, okay? Ignore karanna onne. Yeah, so what do you think this is? Again, optic disc is blurred. You see all these hemorrhages, but the hemorrhages have a very nice shape to them. Right? So these are called, what are these called? These hemorrhages, they are called flame-shaped hemorrhages. You see a few exudates. And here you see something called AV nipping. Can you see the artery crossing the vein? You see a sort of notch-like thing there. AV nipping. So this is patient with grade 4 hypertensive retinopathy. The disc is blurred, there are exudates, and there also you see a lot of these flame-shaped hemorrhages. Very typical of that. This is again proliferate. Sorry, this is again hypertensive retinopathy. You can see all these flame-shaped hemorrhages. And you can see this silver wiring method. So the features of hypertension on the fundus are silver wiring and AV nipping. AV nipping. And when the artery crosses the vein, a small notch is formed. That's called AV nipping. Silver wiring, AV nipping. Right. And these are flame-shaped hemorrhages. This is something called a macular star. I don't think you need to worry about that. Again, seen in hypertensive retinopathy. Right. So what are the features then? Write down of severe hypertensive retinopathy. Blurring, again, this is severe blurring of the optic disc, right, is one. 2, flame-shaped hemorrhages, widespread sort of exudate looking whitish things, patches everywhere, right? Plus the macular star can also be seen, macular star. Macular star. Hari. Right. Right. Okay. Fine. This is another one that you can get. This is a hemorrhage with a pale center. Hemorrhage with a pale center. This is a Roth spot, what you get in endocarditis. Roth spot. And in the Danita fundi, I'll just go through this again. Papilledema, very, very common. Make sure that you look at it before you go. Then optic atrophy, and then diabetic retinopathy, non-proliferative, proliferative, hypertensive retinopathy, stage 4, very common OSCE. This is again the same, right? Macular star is also seen in grade 4 hypertensive retinopathy, and this is a Roth spot. Right. Now here, this is not a very common fundus, but you can see this. This is called a cherry red spot. Right? This is central retinal artery occlusion. Right? When you see hemorrhages everywhere in the fundus, this is all over the place. This could be hypertensive retinopathy. This is actually, you see hemorrhages all over the place. The other differential diagnosis that comes into the picture is central retinal vein occlusion. In hypertension also you can get this sort of appearance, I agree. But the differential always, when you have hemorrhages everywhere, red everywhere, is central retinal vein occlusion. And this is quite clear. You can see this very nicely in a very localized vascular territory. Hemorrhages in a very beautiful, demarcated, localized vascular territory. This is branch retinal vein occlusion. Branch, BRVO, branch retinal vein. Sorry, BRVI anyway, BRVO. Branch retinal vein occlusion. Right? It occurs in a very nice, demarcated vascular territory. What is the fundi? Right? These are the fundi. This is not very important. Okay, the ඔයිටික තමයි ප්‍රධාන වශයෙන් අපිට තියෙන්නේ තව stations එකක් තියෙනවා අපි බලමු. These are all spot diagnoses. Yeah.
Sir, dot and blot hemorrhages ඒතර diabetic වල විතරද තියෙන්නේ hypertension වල?
Hypertension dot and blot hemorrhages එන්නේ. Hypertension hemorrhage ආවත් එන්නේ අර නිකන් flame shaped hemorrhages වගේ දේවල්.
Sir, මේ diabetic වල proliferative non-proliferative
Sir,
කියලා ඩිස්ක් එකේ තියෙන මේ විසල්ස් ගානින් හිම හොයන්න බැරිද නැත්නම් අර වගේ සර් පෙන්නවා වගේ හොඳටම congested එකක් වෙන්න ඕනේ.
ඔව් මේ වගේ වෙන්න ඕනේ. පොඩ්ඩක් හරි proliferation තියෙනවා නම් ඉතින් ඒක අදාළයි. හරිද?
හරි.
ඒක බලන්න ඕනේ පරිසම. මෙච්චර obvious නෙවෙන්නත් පුළුවන් සමහර වෙලාවට.
Sir,
Actually,
rod spots තියෙන එක sir rod spots තියෙන එක පොඩ්ඩක් තව පාරක් explain කරන්න පුළුවන් sir ඒට.
Oh, Roth spots can measure. You have a hemorrhage with a pale center. That is the only thing that you see. Hemorrhage එක වටේ ඇතුලේ බැද නිකන් හිස් වගේ. That is a Roth spot. Right? Right.
Sir, retinal hemorrhages කියලා එතකොට වෙනම එකක් ගන්නවද නැත්නම් ඔය dot
Oh, වෙනම තියෙනවා ඔය pan retinal අනම්මන ඒවා ophthalmology. ඒවා medicine වලට අහන්නේ. Hemorrhages කියලා medicine වල අහනවා නම් මෙන්න මේ වගේ එකක් Roth spot එකක් වෙන්න පුළුවන්. Or of course you can get this sort of thing with hypertensive retinopathy. ඒක තමයි වෙන්නේ. සමහර diabetes patient කෙනෙක් වුණත් දැන් මෙච්චර neovascularization තියෙනකොට පොඩි hemorrhage එකක් තියෙන්න පුළුවන්. හැබැයි ඉතුරු features උත් තියෙනවා. ඒක ඔයගොල්ලෝ අඳුර ගන්න පුළුවන් වෙන්නේ. හරි? Right. Okay. So next one is easy. We're just asking for this. What is that? That is a very nice picture of an Eshka, scrub typhus. Are you getting put spot diagnosis? Right. Okay. Right. Now then you have a series of course, things like the blood gas analysis වගේ දේවල්. Blood gas මතක තියාගන්න අමාරු ඒවා දෙන්නේ නැත. ඕගොල්ලන්ට සාමාන්‍යයෙන් දෙන්නේ this one which I am showing you now. Right, so have a look at this. This is the most commonly given blood gas as an undergraduate. You will find this is the most common. ගොඩක් අමාරු ඒවා දෙන්නේ නැහැ. ඔය anion gap හදන්න ඒවා එකක්වත් දෙන්නේ නැහැ. Very straightforward respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis. Very straightforward, simple level තමයි දෙන්නේ. Right? Right? So don't worry. Here it's quite obvious. So how do you say what it is? pH එක බලනවා. You decide, is it acidosis or alkalosis? First thing to do. Second thing to do, look at the carbon dioxide. If the change in carbon dioxide explains the pH, if the change in carbon dioxide explains the pH, that is a respiratory abnormality. If the change in carbon dioxide is opposite to the pH or does not explain the pH change, that is metabolic. Right? Right? And remember, blood gases are never compensated. Compensated pH එක normal වෙන්න එපා. ඒවා compensation හදන විදි තියෙනවා. ඒවා ඔයගොල්ලන්ට වැදගත් නැහැ. So most of the time you will get an uncompensated blood gas. Look at the pH. If the CO2 is in the direction of the pH or it explains the pH, it is respiratory. If it does not, it is metabolic. So here you can see pH low, acidosis with a high CO2. So the pH is explained by the CO2. So therefore it is respiratory acidosis. Itamatara, you see hypoxia also. So this is actually type 2 respiratory failure, to be more specific. අපි emergency medicine කරනකොට සහ long case කරනකොට මේක ගැන කතා කරා, that I told you that you need to consider non-invasive ventilation in patients with COPD when they have type 2 respiratory failure. So that is quite simple. Most of the time you get a type 2 respiratory failure ABG, metabolic acidosis ABG, right? Nothing beyond that, don't worry. Right. Any questions up to now? And Amaru blood gases, then I will guarantee that, don't worry. Right?
So
Now, this is...
Oh, so this is not regarding the blood gas itself, but Anita Nikangara stations are Nikangara Tiara values then the ranges, Saman ranges.
Yeah. Values they know. Then no.
Okay.
Right. Normal ranges should be given. It's very difficult to do it without that, obviously. Right. Okay, station number 14. Now, this is an unusual thing, but keeps on appearing in OSCEs. If you are not careful, you will get caught out. Maybe gram stain there. Gram positive, gram negative organisms. Now, here, of course, is gram positive. You can see this grape-like clusters of organisms, which is very typical of Staph aureus. So, parana microbiology notes, gram positive, gram negative, cocci bacilli, right? That is podi story එකක් දීලා ඉතින් ඕක ගැන gram stain එකක් දෙනවා සාමාන්‍යයෙන් පණ්ඩුකස, so be ready. Right. This is a gram positive, the purplish color is gram positive, because this grape like clusters very typical of Staph aureus. Right. Another thing that Chang sir likes to give is videos, and these are some of the gates that you can okay. Okay, so I bala. Okay, so you can see this bilateral high stepping gait, bilateral foot drop. This occurs mostly in distal neuropathies. Okay, mostly in distal neuropathy, bilateral foot drop. You can also get Parkinson's gait, hemiplegic gait also. Right? So be ready for that. You are definitely going to get a video with a gait. Right? Chang sir likes that quite a lot. Right? So be careful. Right. Okay, so this is another sort of data interpretation scenario. I'll give you about a minute to read this. Okay, so there's something iron deficiency, probably hemoglobin low, MCV low, something story going on, but that's not what the focus is. The focus is this hyponatremia. Then Sabharata, they might give you hyponatremia, maybe a few questions in the Viva also. May OSCE or Viva එකේ පොඩි පොඩි ප්‍රශ්න කීපයක් අහන්න පුළුවන්. I'll just very simply explain hyponatremia. Very, very simply. Hyponatremia is a very complicated topic, but very simply, if you look at it, there are 3 types of hyponatremia. 3 types. One, there is hypervolemic hyponatremia. Hypervolemic hyponatremia. Then, මොකක්ද hypervolemic hyponatremia කියන්නේ? Hypervolemic hyponatremia is fluid overload causing dilution. Right? Hypervolemic says fluid overload, වතුර ගොඩයි, causing dilution in hyponatremia, which occurs in heart failure very often. Heart failure. Dilution, that is hypervolemic hyponatremia. On the other end of the spectrum, you will get hypovolemic hyponatremia. Any patient, vamanidano, diarrhea, whatever, loses a lot of salt and water, right? So they get hypovolemic hyponatremia. Hypovolemic hyponatremia. Somehow diuretics in the window. Hypovolemic hyponatremia. So hypervolemic, hypovolemic hyponatremia. Then in the middle you have euvolemic hyponatremia. Euvolemic. Can a volume? The body fluid volume does not change, and they are hyponatremic. The most important cause of, there are 3 important causes of three important causes of euvolemic hyponatremia. And that's what they ask you for the exam also. 3 important causes. SIADH is one. Second one is Addison's disease. Addison's can also cause hypovolemic hyponatremia, but euvolemic also. So euvolemic hyponatremia, Addison's disease, and hypothyroidism. So those are the 3 important causes: Addison's disease and hypothyroidism. Okay. In all 3 of these, there is a similar biochemical pattern. In all 3 of these, there is a similar biochemical pattern. I will take SIADH as the key example here. What is the similar biochemical pattern? So in SIADH, there is inappropriate ADH secretion, right? So there is a fluid retention, okay, making the urine more concentrated. Now remember, make a volume, there is relative fluid accumulation. It doesn't cause hypervolemia, but there is a cutoff, right? But there is inappropriate ADH secretion, making the urine more concentrate, more sandra. So the urine osmolality will go up, usually more than 50. The urine osmolality will go up more than 50. Because the urine is more concentrated, the urine sodium concentration also rises. Right? So high urine osmolarity more than 50, high urine sodium concentration more than 20. That is the cutoff, more than 20. And because there is water retention, the serum osmolarity goes down. The usual serum osmolarity is around 285. The serum osmolarity goes down. So that is the pattern, which is also called the SIADH pattern. So the pattern is urine osmolarity high, urine sodium concentration high, serum osmolarity low. That is the SIADH. Okay, SIADH, Addison's, hypothyroidism. All 3 conditions you can see a similar biochemical pattern. Right. But all of you know, in Addison's disease, there are certain other features. The Maya patient, so serum sodium low, urine sodium is concentration more than 20, which is concentrate. Urine osmolarity is more than 50, it's 205, 4 times higher, again is high. And serum osmolarity normal is 285, now it is low, 265. So you know that there is definitely something going on there, right? So this is an SIDH pattern which can occur in Addison's, but in Addison's there are certain other clues, and this is one of them. You can see this pigmentation, hyperpigmentation, and potassium will also be relatively high in Addison's. So this is Addison's. But Addison's remember the three types of hyponatremia: hypervolemic, hypovolemic. They are more concerned about the euvolemic one, where you have SIDH, Addison's, and hypothyroidism as causes. In all three, the pattern is similar: serum osmolality low, urine osmolality high, urine sodium concentration high. Okay. ඊට අමතරව sodium ගැන මුකුත් දැනගන්න ඕනේ නැහැ. The other thing about sodium is you do not give hypertonic saline for correction of hyponatremia unless the patient has symptoms, like unconsciousness or seizures. You do not use it. It's very, very dangerous. Very, very dangerous. Okay, right. Now, station 17 is a case scenario focusing on dengue, right? And we have discussed dengue before. I'm not going to go through this in detail. I'm just going to let you read it and sort of figure out what's going on, right? But there will be some dengue katandare or COVID katandare here. Dengue katandare තමයි very pura. COVID chest X-ray එකක් දෙන්න පුළුවන්. Might get that. So ඔක්කොම හැමතැනම සුදු පාටයි. I think COVID මවට පෙන්වන එක. හරි.
Excuse me, sir.
Yes, Irving.
Sir, in the previous one, how do we determine whether the patient is hyper or iso?
ඒක ගොඩක් වෙලාවට මම අතර මේක දීලා නැහැ, but usually ඒක දෙනවා I think history එකේ.
Okay, sir.
Yeah. නැත්තම් බෑනේ, obviously you can't differentiate that just right. Then you tell you in the history that patient is not dehydrated හරි මොකක් හරි මොකක් හරි පොඩි clue එකක් තියෙනවා. Right? Okay. This one. So general katandra ටිකක් දීලා තියෙනවා, usual sort of information, and then the more important story is what happens here. Right? So tachycardia. So we know that the story is sort of worsening. I told you about early recognition of shock, so that's quite concerning to us. The BP is okay for the moment, right? But the PCV you can see is going up. So we know that the patient is now sort of entering the critical phase, right? So ඒ වගේ determination එකක් වැදගත්. Urine output is around 1 ml per kg power, but still we are not completely out of the woods. Hari. Now what has happened? So that's a scan. You can see that there is leaking there, and I told you about leaking. Ultrasound scan, the importance of diagnosing that through ultrasound scan. Next step in the match is usually critical phase. We talked about this. So fluid quota about 100 cc power. Shape පොඩ්ඩක් වැඩි කරලා දෙන්න පුළුවන් මෙතනදී. පොඩ්ඩක් tachycardia එකක් එහෙම තියෙන නිසා, right? The abdominal pain is important. There might be some transaminase elevation, liver problem, so it's important to have a look at that also. Right. Then මේක තමයි වඩා වැදගත්. Now you can see the patient is in shock. Right, very clear. BP low, pulse pressure is 20, tachycardia, urine output 0, and already. But the most important thing for you to gather from this is the PCV is 40. You can see that the PCV when the patient came in was 45. When the patient started leaking, it went up as expected to 52. Now what has happened? It has gone down to 40. Patient is in shock. What is the next step in the management? දැන් මෙතන පොඩ්ඩක් මම ප්‍රශ්නේ හරියට වර්ඩ් කරලා නැහැ, but obviously you need to start a bolus, but most important thing you should do is transfuse blood, because it's very, very clear that the patient is hypotensive because of bleeding. නැත්තම් PCV has dropped by 12 නේද එකපාරට, PC 52 ඉඳන් 40ට අඩු වෙලා. Now you know ලෙඩේ තමයි, patient is bleeding, so your most important step is blood transfusion. But obviously to get the blood, it will take time. Until that you have to give some fluids to get the blood pressure. But blood transfusion would be the key thing in this patient's management, obviously. Right? So, ඒ වගේ පොඩි මොකක් හරි dengue scenario එකක් දෙන්න පුළුවන්, because it's important, it's common, and you need to know about it. Right. Okay, මේක එච්චරම වැදගත් නෑ. You can have a read about this later. Right. දැන් අන්තිමටම ඔය toxicology වලින් දේවල් දෙනවා. හරිද? toxicology වලින් දේවල් දෙනවා. මේ පොඩක් ඔය පැල අනම්මනන් ටික බලා ගන්න. හරි ඔය කදුරු දිවි කදුරු අනම්මන මේක ද්වි කදුරු ගොඩ කදුරු වෙල් කදුරු අනම්මන ඔය පින්තූර ටිකක් බලාගෙන යන්න. නියංගලා තව මොනවද දෙන්නේ මේ ඔලියන්ඩර් කණේරු ඒවයි පින්තූරෙන් බලාගෙන ඔය ඉදිරියට දෙනවා. හරිද? කළා ඒකේ තියෙන ටොක්සින් එක මොකද්ද? ඇන්ටිඩෝට් එක මොකද්ද? ඔය ටික බලාගෙන යන්න. හරි? නියංගලා මේ ඔලියන්ඩර් this is නියංගලා this is oleander. Right? Yellow oleander කණේරු. Right? So you need to know this. Right? හරි. ඊට පස්සේ මේ නයිට් ටික obviously දැනගන්න ඕනේ. අපි කතා කරා about management of snake envenoming. So crate, Russell's viper. This is a green pit viper, ne? Still mildly venomous. And this is a මොකද මේ hump nose viper. So you need to know to identify. This is not venomous. This is a wolf snake. අර මෙතන මේ මුගේ බෙල්ල වටේ තියෙන ring එකෙන් තමයි අඳුරගන්නේ. It's compared to the crate. ඔළුව පේන්නේ නැහැ. Okay, night එක බලා ගන්න, පැල ටික බලා ගන්න. ওই ටික තමයි ඉතින් දෙන්නේ. Right, so if you were to split it down into various components, ECG, chest x-ray, blood film, fundus, toxins, some data interpretation, ඒ ටික තමයි ඉතින් මේකේ තියෙන්නේ. හරි? Gate examination, blood gas, ඒ වගේ components මම ඔක්කොම ටික මේකේ cover කරා and I've just given you an idea of what sort of things they might commonly given නේ. එක section එකේ මොනවද වැඩිපුර දෙන්නේ කියලාත් මම උගලට කිව්වා. හරි. ප්‍රශ්න මොන හරි තියෙනවද? අපහැදිලි තැන් අහන්න.
So මේ අර ඇඩ්වයිස් දෙන ස්ටේෂන් එකක් සාමාන්‍යයෙන් තියෙනනේ සර් අර කමියුනිටි.
Oh, advice or some sort of breaking bad news හරි මොකක් හරි ඒ වගේ. ඔව්. ඇහෙන්නේ ආශිර් වගේ. ලයින් එක ඉච්චර.
නැසෙ ඒක අහන්නේ සාමාන්‍යයෙන් normally අහන්න පුළුවන්.
පුළුවන් ඒක. ඔව් ගොඩක් වෙලාවට ඔය මොනද communication skills වලට දෙන්නේ මේ consent ගන්න වගේ එකක්. මොකක් හරි invasive procedure එකට consent ගන්න එකක්. එතකොට මොනවාරි renal biopsy, endoscopy ඔය මොකක් හරි මේකට consent ගන්න එකයි. සාමාන්‍ය ඔය මේ ලොකු අමාරුවක් නෑ නේද? අර paper වල ටික ලස්සනට ඒක කියන්නේ. අනිත් එක breaking bad news. ඔය දෙක තමයි දෙන්නේ. සාමාන්‍ය. Consent procedure එක consent ගන්න එකයි breaking bad news. So the two that are commonly given. Communications. මම හිතන විදිහට තියෙද දන්නේ නැහැ මොකද මේ පාර මේ ස්ටාෆ් එකටත් ඉන්න බෑ වගේ ප්‍රශ්නනේ ඉතින් උතන ඉන්නත් මිනිස්සෙක් එපා මම හිතන්නේ නැහැ දෙයි කියලා දන්නේ නැහැ ගොඩක් වෙලාවට paper based වෙයි ඔය පින්තූර x-ray ECG මේ blood gas වගේ තරක් වෙයි ගොඩක් දුරට
සර් රෙජිස්ට්‍රාර්ලා කිව්වා මේ අද රෙජිස්ටර් කෙනෙක් කිව්වා මෙහෙම අර මේ අපිට ප්‍රිපෙයාර් වෙන්න තියෙන OSCE එකට කියලා. ඒකින්ද මේ
කිව්වාද එහෙම සමහරට ඇති උන්ගේ මොකක් හරි එකක් ගල්පා කියලා. සමහර හිස්ටරි එකක් ගන්න වගේ දේවල් දෙනවා. everything ඒ එන විදියට ඉතින් ගන්න ඕනේ ඉතින්. මොකක් හරි joint pain තියෙනවා මෙයාට හිස්ටරි එක ගන්න ඔය වගේ මොකක් හරි මේ වගේ ඒවා දෙනවා. ඉතින් ඒවා ඉතින් අමාරු නෑනේ. හරි. right එතකොට ඔයගොල්ලෝ පාස් ඉස්සර දීපු ප්‍රශ්න එහෙම දැන් ඔයගොල්ලෝ කරනවා තියෙනවනේ කට්ටිය එකතු කරපු ඒ මොනවා හරි ගැටලු තියෙනවා නම් දාන්න group එකේ මම ඒකට අදාළ මොකක් හරි විස්තරයක් කියන්නම්. ඔව් දැන් ඔයගොල්ලන්ට අර මට short cases ටික තමයි කරගන්න බැරුණා පීගා group එකත් එක්ක ඒක කරමු. අනිත් ටික නම් ඔක්කොම කරානේ long cases කරා emergencies කරා OSCE කරා වයිව කරා මොනවද?
නෑ සර් sorry.
හරි එතකොට ඊගාව group එක කරනකොට මම පිපුණේ ඔයාලට message එකක් එවන්න short cases කරනකොට අනිත් ටික ඔක්කොම අපි කරලානේ තියෙන්නේ.
හරි සර්.
හරි කළා මොනවද දැන් මේ ගැටලු තියෙනවා නම් ඔය OSCE වයිව වලට අදාළව ඒවා දාන්න දැන්. දැන් වෙලා තියෙනවනේ පාඩම් කරගන්න හෙටයි අනිද්දායි දෙකම තියෙනවනේ බලා ගන්න නේද?
ඔව්.
හරි හොඳට කරන්න. හරි එහෙනම්.
හරි සර්.
හරි ඕකේ. හරි
thank you
bye.
sir මේ අපි
මොකක්ද thank you කියන්නේ නෑ තාම ඉවර නැහැ බං තාම ඉවර නැහැ ඉවරුනාම
හරි
කියපන් තාම ඉවර
හරි
නැහැ
හරි
ඉවරලා ෆයිනල් රිසල්ට්ස් ආවට පස්සේ කියන්න තාම ගොඩක් වැඩ තියෙනවා තාම මේ ඉවර නැහැ
මේ අපි ප්ලෑන් කරලා තියෙනවා මේ ඔන්ලයින්
මොකක්ද?
පාටි සංග්‍රහයක් එහෙමස
ඔන්ලයින් පාටි සංග්‍රහය
ඇස මේ ඩිස්කස් කරාද මේ අපි ඉසට පිප්නි කතා කර ඉසාරයට මේ මොකක්ද
ආ හරි හරි හොඳයි නවුලන් මොනවද තැපැල් කළ ඉවර එංගලන්තෙට මේ දාලා කෑකේ එකක් හරි හරි
Hi, sir.
හරි හරි
Thank you, sir. Thank you so much.
හරි හරි ඕකේ බයි
Bye.
thank you very
Bye.
much sir.
හරි හරි
Thank you, sir.
හරි ඕකේ
Thank you, sir.
Thank you so much.
Thank you, sir.
Thank you, sir.
Okay,
Thank
bye.
you,
Thank you, sir.
Ayo.